It's 10:05, so let's start. Everyone is good? No worries, that's okay. No, there is no TBL. I posted an announcement in the class. Please, there is only clinical case, which I will post today. So everybody is good. Let's get in our Zen, okay, everyone? Let's get in our Zen. So please see, first of all, that the session this week, everybody's can hear me well. I'm not cutting off. The session, yes?
Yes, ma'am, we can hear you.
Great. So please see that the sessions was run differently this week, and which should not have been. So that is why the old PowerPoint has been taken off the canvas. I'm going to post this PowerPoint with right topics and right questions in the on the canvas today after discussing it. Has everybody got this new interactive PowerPoint, please? So what which I'm discussing. Okay, great, great. So let's start that. So everybody's good. So please see that you have only two topics. Let's start our interactive sorry. Sorry. Let's start our interactive session. Please, this is last minute for me. I compiled the slides as best as I could. But see that your sessions, please be very sure you only have two topics on GI exam, one in heme metabolism and another is iron metabolism. Please know that heme metabolism will be tested more than iron, because keep an eye on that, because you have heme synthesis, porphyrias, heme catabolism, jaundice. There's a lot in heme than iron. So heme will be tested more than iron, just to let you know. I will post the correct interactive session today. I have tried to compile it as best as I can with last minute that I had. Also, please see that there is no TBL. I have posted that announcement on the Canvas page already. There's only a clinical case. And I will post this PowerPoint also today, and I will go over this PowerPoint in next Friday. Does that make sense? Okay, everybody is good now. Please stick to your learning objectives. Let's start with our interactive session. Heme will be tested more than iron. Lot of concepts here. So let's see what we started, and let me tell you how you have to go about heme. Since it's an interactive session, I will do it the same way. I will discuss both topics for the exam, which is heme and iron. We did talk about B6 deficiency, lead poisoning, yes, which is the second step. We talked about B6 deficiency, lead poisoning. Now, B6 deficiency, lead poisoning, and iron deficiency. So, please also note with this, whenever I come to your to our interactive session, I also try to see that you're prepared for the exam. I always do a we talk. Unfortunately, I'm not in person in the class, but we can still do it now. So tell me, we talked about B6 deficiency, lead poisoning, and iron deficiency. What was common to them? So try to do common presentation and then differential. How can you differentiate each one of them and come to a conclusion whether it's B6 deficiency, lead poisoning, or iron deficiency? So what is common to all of them? What is a common presentation? Very good. I like that. Microcytic anemia. Then you divulge. Okay, this is microcytic anemia presentation, but tell me, B6 deficiency, lead poisoning, or iron deficiency, where do you see abdominal pain and irritability? Where do you see abdominal pain and irritability? GI symptoms. Now, see, you're answering AIP. Did I start with that question? You're more focused. You're on the question. What is presented in the question? Better grades. I asked you. First of all, I asked you, can you see my laser pointer? So I asked you, we did B6 deficiency first step, lead poisoning second step, but B6, lead poisoning, and iron deficiency all present with microcytic anemia. But now you have to differentiate. Just microcytic anemia cannot give you to these diagnoses. So to confirm diagnosis, which one is what? Which of them presents with abdominal pain, irritability, B6 deficiency, iron deficiency, or lead poisoning? Where have you seen these? Mm-mm. Lead poisoning, lead poisoning. Yes, lead poisoning has abdominal pain and irritability. Some of these abdominal, GI, and neurological symptoms more with lead poisoning. Then, okay, even if this is non-specific for people, let's see where will be ALA low. B6 deficiency, because you know microcytic anemia. But now you have to confirm. So B6 deficiency, lead poisoning, or iron deficiency, where will be ALA low? B6 deficiency. So you keep confirming your diagnosis. So take the common finding and differentiate between these clinical presentation. That should be your aim for heme pathway. Yes, we will go clinical, but still we are going back to the steps. Okay, very good answer. Now, when you say B6 deficiency, iron deficiency, and lead poisoning, where do you see low ferritin stores? Specifically, low ferritin stores will be low ferritin store will be B6 deficiency, iron deficiency, or lead poisoning. Iron deficiency. So you got to go specific then. Microcytic hypoanemia is just a broader question. So you don't jump. When you see microcytic anemia, you don't jump to B6, lead poisoning, iron deficiency. No. See if ALA is low, it's microcytic anemia due to B6 deficiency. Okay, very good. Somebody's iron deficiency. Now, for example, if you had a history of paint, glaze, potteries, batteries with microcytic anemia, where would you go? Iron deficiency, B6 deficiency, or lead poisoning? So you understand what I'm saying? Microcytic anemia, you should not jump to the answer. ALA changes, you should not jump to the answer. First C is ALA high, ALA low. Okay. For example, now let's go further. What was the next thing I addressed? So see, I have already did a recap. I didn't come into the class, but I did a recap of heme metabolism as well as iron, and I've shared the two recaps. So the next we taught is, do you see my cursor? We taught AIP. Now AIP should confuse you with what? For example, hi Ella, will you jump to lead poisoning and AIP both? So, okay, what is common to lead poisoning and AIP? Is Ella high in both? What is common? So something is common, but yes, very correct. So Ella is high in both lead poisoning and AIP. But then if they say PBG deaminase deficiency and high Ella, what are you thinking? PBG, are you thinking lead poisoning or AIP? PBG deaminase deficiency and high Ella. AIP. So you understand, don't jump. And also, this is one thing. Seeing high LR, don't jump to AIP. Don't jump to lead poisoning. See the other findings also. You got to read the case carefully, question carefully. Similarly, similar is seeing microcytic anemia, you can't jump to B6 deficiency, iron deficiency, and lead poisoning. You got to differentiate. So please go that way. Now, secondly, for students, it is whatever, but you got to be careful. Are they saying Euro 1? Are they saying Euro 3? Are they saying ALA, PBG, porphyrins, or protoporphyrin? So tell me, where is protoporphyrin raised? Where is protoporphyrin raised? B6 deficiency, lead poisoning, or iron deficiency? Where is protoporphyrin raised? B6 deficiency, lead poisoning, or iron deficiency. See, lead poisoning. So if porphyrins are different, it may be whatever for you, don't do that. Porphyrins are these uroporphyrins. Euro is also 1 and 3, right? Protoporphyrins are porphyrins, but they are not uroporphyrins. So the word porphyrin is different from protoporphyrin, which you see it here. Others are porphyrins. This is protoporphyrin. So please be mindful. It is not whatever, right? Does that make sense? Very good. If you see high protoporphyrin, you're thinking lead poisoning. You're not thinking B6 deficiency, iron deficiency. Instead, in B6 deficiency, what will happen to protoporphyrin? High or low? In B6 deficiency, what will happen to protoporphyrin? low. So this is important for you, please. And these distinctions are important for you. Also, wherever you accumulate porphyrins, there will be cutaneous symptoms. So now let's go to CEP. Now, CEP, I just want you to remember that this is the place. You see this cursor where first cutaneous porphyria starts. AIP is not cutaneous. I hope you know that. Is AIP purely neurological? Is AIP purely? Yes. So first cutaneous porphyria, I don't want you to put this porphyria CEP into any category, except knowing that this is the first porphyria where cutaneous symptoms starts. But tell me, in CEP, cutaneous symptoms are because of high Euro 1 or high Euro 3. In CEP is this one. In CEP, the cutaneous symptoms are because of high Euro 1 or high Euro 3. High Euro 1. So see, it's specific. Is Euro 3 high in CEP? Is Euro 3 high in CEP? Is Euro? No. So you can mess up with that. You cannot mess up with the step. It's step intermediates, a substrate and product. Right? So keep doing that for me, please. Secondly, this is the most common cutaneous porphyria. I have already told you PCT. AIP is the most common neurological. CP is the first one when cutaneous symptoms starts. But cutaneous symptoms in CP, very good. I like that answer. You got to be specific for good grades. It is because of accumulation of Euro 1. Right? You understand what I'm saying? Has to be specific. Other porphyrias below the down the line are good for boards, but right now I would at least tell you you should distinguish purely neurological AIP from purely cutaneous PCT, and where first cutaneous symptoms start CEP. Does that make sense? The last thing is I've already addressed this last step. Last step has a lot of things. Last step may be affected when there is no iron. Yes? Yes or no? If you have low iron, cutaneous is not pure, the CEP is not purely cutaneous, you can say that. I would not call it neuro, but it's just the first porphyria, because I want to be very specific, because otherwise students get confused. I would say label CEP as the first porphyria where cutaneous symptoms starts. AIP, there is no cutaneous symptoms at all. Does that answer the question? Great. So now look at the last thing. So there are a lot of common findings. Don't get confused. There's still a confirmatory diagnosis, but that's up to you how you do that. For example, last step can be affected by iron, if iron is not available, or by lead poisoning. So tell me, if iron is not available or if there is lead poisoning, what will accumulate in these two patients? If iron is not available and there is lead poisoning, what will accumulate in these patients? Protoporphyrin or zinc protoporphyrin. So you see, everything is around the step. But now, okay, if the iron is not available and there is lead poisoning, there will be high zinc protoporphyrin. But now, in which one there will be sideroblastic anemia? When iron is not available or when there is lead poisoning. Even then, there is distinction. So tell me, when iron is not available or when there is lead poisoning, that you have sideroblastic anemia. Lead poisoning, because sideroblastic anemia means iron deposited as a ring around RBC. Iron should be available. If iron is not available, how it will get deposited outside the RBC? So yes, lead poisoning. So do you understand that how clinically they sometimes clinically they have a common presentation, sometimes biochemically they have a common presentation, but they still can all be ruled out. So please keep an eye on that. Then treatment of any enzyme deficiency, keep talking. So what would you do in a treatment? Either you remove the substrate, or you supplement the product, or you replace the enzyme, or you replace the cofactor. But one thing you could also do, I don't like going back, but I'm going back. One thing you can also do is inhibit this rate-limiting enzyme. So you prevent the forward synthesis. Backup is already happening. Why do you want more forward synthesis? So then keep an eye on your treatment modalities. Does that make sense? This is how I discuss this lecture with you. Yes, mature RBC cannot do this pathway because they lack mitochondria. Yes, it is done only in a premature precursor erythrocyte cells. First was B6, two was lead poisoning. What was three? Three. What was three-step defect? Three-step defect, AIP, very good. It's okay. You still have a week. You don't have to answer quick. Only review it. So don't get disheartened by people answering question. Four is CEP. Five is PCT. What's eight? What's eight? Which poisoning is eight? Which poisoning is eight? Sorry, I got to see your chats too. Lead poisoning. Is lead poisoning also affecting any other step apart from eight? Apart from eighth step, is lead poisoning second step, not first. Somebody said first. First is not lead. First is B6, right? Second is lead. So you got to address these steps. We got to go biochemically too. Please know that when you go higher up, you will learn clinical again. No one is going to address the biochemical aspect. That's why I like to teach you, go back to the step, right? Does that make sense? So you are good with heme synthesis. Let's do this question. So now let's try to differentiate. First of all, I have given you this PowerPoint, okay? So tell me, just looking at this question stem, is it neurological porphyria or cutaneous? Because you do see LI and PBG, but by symptoms, is this purely neurological or is it purely cutaneous? Tell me. Is it purely neurological or you see some cutaneous symptoms? Or it's just purely neurological? If you look at the question stem, what cutaneous symptoms are you seeing? No, it's purely neurological porphyria. It's a purely predominantly neurological porphyria. So now you go to probable diagnosis. Oh, I think it's AIP. It could be others too. So then you see what is accumulating. Now you see ALA accumulating. Can you go to lead poisoning? You see high ALA. Can you go towards lead poisoning? Yes, but why will you not go to lead poisoning? What is missing in the history that you should not go to lead poisoning? What is missing in the history that you should not go to lead poisoning? So jumping to seeing Allah is not good. No, no exposure to lead, no paints, glaze, potteries, batteries, no metal stuff, no paint stuff. How can you go to lead poisoning? But what confirmed your diagnosis is along with Allah, what is also increasing? PBG. That confirms AIP. So one, don't go to one independent parameter increase. See what both together is making sense. If LI and PBG are high, can you think about anything other than AIP here? Yes, lead poisoning can also have abdominal pain. I like that observation. But again, first, high LI and high PBG together. Can you think of anything other than AIP? Can you think of anything other than AIP? Are LI and PBG both increased in AIP? Yes or no? Yes. In fact, if you chose lead poisoning, is PBG increased in lead poisoning? Is PBG increased in lead poisoning? No, PBG is low. So please be mindful of both. If one is given, even then be careful with the history. If both are given, then be careful where both of them can be high. Can't be lead poisoning. Somebody raised a very good question. Why not? Again, looking at abdominal pain, irritability, don't jump to lead poisoning. There's no pain, glaze, pottery history. And there is ELA and PBG is not high in lead poisoning. You get my point? Where someone is very right. Abdominal pain can throw you off and you can think it's lead poisoning. Mm, environmental factors too, right? Does that make sense? So let's get to the A. Now, A is lead poisoning. Yes or no? Dehydratase. So is it a correct answer? Always rule out your answer. No. Yes, why not? Drinking water, but water is more fluoride rather than lead, but anything. I understand anything, but there should be a lead poisoning exposure, lead exposure. You get my point? So LR dehydratase is right for this question stem. I will try to finish, but since you have not learned the concepts in the IS, I'm just trying to please give everything. I'll try to finish in 50 minutes, but this is your first time learning it, so I'm trying my best. Does that make sense? Yes, you can ask question. I just wanted to first finish this. So Ella dehydratase inhibition is what? Lead poisoning. Does it look like a lead poisoning history? A case? So should A be wrong? Yes. A should be a wrong choice? Yes. Yes. What question you have? Sure.
So like I'm a little confused in the vignette specifically if we take out the like enzymes and well the porphyrin, what are the neurological? Because you mentioned cutaneous and neurological. I'm
Yes.
not seeing it. Where is it in this vignette, please?
First of all, there is abdominal pain. So, what is neurological about this? When you say AIP, what accumulates in AIP is LI and PBG. They are both toxic to abdominal nerves. That's why they cause abdominal pain. Yeah, they also cause neuropsychiatric symptoms, which might not have been here, but there is abdominal pain.
Okay,
Let,
say neurological, it's the nerves being affected, not
yes,
okay. Thank you so much.
not just neuropsychiatric symptom. Good question. Good question. This is your chance to ask question because you're learning for the first time, unfortunately, but it is your chance to ask question. B, can B be a possible answer? Why not? Because you are thinking about AIP. But please, PBG deaminase is also known as, anyone wants to answer that? PBG deaminase enzyme is also known as HMB synthase, so don't be thrown off. PBG deaminase is also known as HMB synthase. So B could be right. What about decarboxylase? Where is decarboxylase effect? CEP or PCT? PCT, purely cutaneous, chronic.
Did she freeze for anybody else? Yeah, her bug, you're frozen.
Oh, really? I hope
Now
I.
you're back.
Okay, please let me know if I am lagging. There's an internet issue. I can repeat it, but till now I was okay. Okay, great. Let's go further. Don't waste time before internet goes off, right? And let's look at ferrochelatase. What is this defect? Which poisoning you have ferrochelatase inhibition? Lead poisoning. This is not a case of lead poisoning. A beta chain. This was beta thalassemia. This was in the past exam. Why did I put it here? But anyways, this is also not the right answer. So what is your right answer here? Everyone is clear with that? B. Great. So please rule out the answer. Don't get thrown off by the abdominal pain. Just to tell you know that the color change in urine of AIP, CP, or PCT is port wine, please. No, I'm not reminding you of any trauma. I am myself in trauma this week. Anyways, so last minute trauma. So please note that the change in color is port wine. By naked eye, you cannot say that it is AIP or PCT. They got to tell you just by change on color, you cannot distinguish. It could be seen in cutaneous, neurological, AIP, PCT, which is shown here. They got to mention and measure what is accumulating in urine. Is it ALA, PBG, or urine has porphyrins? The type of intermediates, heme intermediate accumulating is important, not just the color. Color is port wine in case of porphyrias. So see, were we discussing this porphyria right now, AIP, right? And what is AI accumulating in AIP? LI and PBG. Is AIP also HMB synthase? Yes, because what are you synthesizing? HMB. I'm trying to explain you, assuming that this is the first time you're learning, right? Does that make sense? I hope it's helping. I don't want to rush. Okay. I will open question answer session, but is there anything you want me to address? Everything is good. Let's move on. Okay, great. So we did AIP. Similarly, do every step and don't be confused. Don't just look at a high ALA, jump to lead poisoning. Similarly, don't just look abdominal pain and jump to lead poisoning. Don't just see high ALA, see what else is also accumulating. Everything is important. Please know protoporphyrins are different from porphyrins. Porphyrins are Euro 1 as well as Euro 3. They are different. Okay. So, yes, this is here. ALA and PBG are toxic to nerves. That is the neurological manifestation. So, and then treatment. Also, please know that what I have asked you to do is lead poisoning, B6 deficiency, differentiate AIP, CEP, PCT. Definitely, there is a clear cut demarcation between AIP and PCT. CEP is only the first porphyria where you have cutaneous symptoms. See, be mindful of this chart. I don't draw them because I love them, right? It's for you to focus on them. And I told you, hi Ella, you can't jump. Sorry, hi Ella, you can't jump to lead poisoning. Hi Ella is also seen in AIP. Please get to please confirm one or two more things in the question stem when you get to your diagnosis, final diagnosis. Then we had, sorry, if I have any question, I also want to address question. Great, everybody is good. So let's see what was in jaundice. There was prehepatic, hepatic, and post-hepatic jaundice. Where was unconjugated bilirubin formed prehepatic, hepatic, or post-hepatic jaundice? Where was unconjugated bilirubin formed? Prehepatic, hepatic. Okay, let's first compare. Where was unconjugated bilirubin? Prehepatic or hepatic? Prehepatic or hepatic? Where was unconjugated bilirubin? Prehepatic. Is this bilirubin, is this known as unconjugated bilirubin? Is this bilirubin in circulation known as unconjugated bilirubin? Absolutely. Does it ever show up in urine? Does it ever show up in urine? No. So that is why you must understand that there are three parameters done to assess jaundice. One is bilirubin in serum. It is different from bilirubin in urine. And then lastly, they do bile pigments. What are bile pigments? Can you give me? Urobilin is in where? Urine or feces? Urobilin in urine and sterco in feces. They are responsible for the color respectively. So write three parameters. Be mindful of that. This does not show up in urine. Then hepatic, there's conjugation. What happens in post-hepatic? Deconjugation. Deconjugation and formation of bile pigments. So this is normal. Now let's do jaundice. In prehepatic jaundice, tell me a common history that will lead to very high unconjugated bilirubin in the circulation. Prehepatic jaundice. Give me one history. Excessive abnormal hemolysis. Let's go to post-hepatic. Please compare first pre with post because there's a very clear-cut distinction. There is isolated high rise of different fraction of bilirubin. You cannot mess up there. Then do hepatic, otherwise you will be confused. In post-hepatic jaundice, where is the problem? Is it excessive hemolysis? It is hepatic damage or is it bile duct damage? Where is the pathology in post-hepatic jaundice? Bile duct obstruction, bile duct obstruction, carcinoma, head of pancreas, stricture, but it's bile duct. So please, history is very important in this block. There is absolutely different history. I have made charts. Pay attention on history. Don't flip-flop them, right? So post-hepatic is CBD problem. Common CBD, I'm not talking about that CBD, right? I'm talking about common bile duct. Be mindful. So, but now, which fraction of bilirubin will rise in the serum in post-hepatic obstruction, whether partial or complete, conjugated or unconjugated, post-hepatic obstruction? Which fraction of bilirubin will rise? Look at my cursor, laser PowerPoint. Which bilirubin will rise in the circulation? Conjugated or unconjugated? Tell me. Conjugated. So if you see rise in conjugated bilirubin very high predominantly, don't pick prehepatic jaundice. right? You cannot pick prehepatic jaundice. You got to pick posthepatic jaundice. Now let's come to hepatic jaundice. Please see, hepatic jaundice is not like a clear-cut rise in a fraction of bilirubin. It's just a ratio. So which ratio in this, which type of bilirubin will be more than the other? Unconjugated or conjugated? If there is a hepatic damage, which bilirubin will be slightly more than the other? Unconjugated will be more than conjugated. So understand the three: different history, different presentation. I will discuss this with the question, right? So the only three parameters that we quickly look into, yes. By pre, you mean prehepatic jaundice. By pre, I mean there's a prehepatic jaundice, there's a hepatic jaundice, and there's a post-hepatic jaundice. Are you clear with that? Okay, good. Yes. So what parameters you have to see? Serum, bilirubin in serum, bilirubin in urine, and bile pigments. So let's go to the question and discuss there how you can differentiate. Did I answer you what is pre means? Okay, I think I did, but we have question answer in the end. Let's finish our topic. So let's look at this question. What do you see in this question? Tell me. Massive abnormal hemolysis. Yes, maybe due to ingestion of the naphthalene balls, but there's massive abnormal hemolysis. By history, you want to put this clinical case down the, do you want to put this clinical case in prehepatic, hepatic, or posthepatic jaundice? First of all, you got to go there with the question stem. You want to put this clinical case by seeing excessive abnormal hemolysis, glucose 6 phosphate dehydrogenase deficiency. It can be sickle cell, beta thalassemia. Where do you want to put this jaundice into? Prehepatic, hepatic, or post prehepatic? So see, start going there. Don't go there as post hepatic. There's nothing like there's no pathology to the common bile duct. It cannot be hepatic. There is no damage to the hepatic system shown. There is no ALT rise. Does that make sense? So you are going to 100%, you are going to, probably you are going to prehepatic jaundice. Now tell me, in prehepatic jaundice, which type of bilirubin rises, conjugated or unconjugated? Conjugated or unconjugated? There is a predominant unconjugated. Does it ever show up in urine? Does it ever show up in urine? No. So will you even pick C, D, or E? Should you even pick C, D, and E as your answer? No. So C, you have to rule out the answer. You're only caught between A and B. Am I right? It could be either A or either B. Now let's look at the right side also. That's why just high Ella will not help you. You need to see what else is rising, what else is low. Similarly, the second finding. Now tell me, in prehepatic jaundice, there is excessive abnormal hemolysis. In prehepatic jaundice, is there any pathology in hepatic and post-hepatic? Is there any hepatic and post-hepatic pathology? No, hepatic is okay. Post-hepatic is okay according to this case. So what will happen? All the unconjugated bilirubin will flow right down and form a lot of bile pigments. So will you see high bile pigments or zero in the urine? Will you see high urobilin or zero urobilin in urine? High. So what should be your right answer then? A or B? Tell me, what should be your right answer? B. Does that make sense? You got to rule out your answers rightly. So B is the right answer. So are you clear with that? With jaundice, how you have to go? We have questions. We can also address the question. So you got to differentiate first prehepatic with posthepatic, very clear cut isolated rice. Enzymes can help too. Alkaline phosphatase is for duct pathology. ALT is for hepatic pathology. ALT is more used than AST. No, hepatic is not more conjugated. So see, no memorization. When you memorize in biochem, you can go wrong. When you're asking me what fraction of bilirubin should increase in hepatic jaundice, is hepatic jaundice because of hepatic damage? Is hepatic jaundice because of hepatic damage? Yes. So when there is a hepatic damage, can hepatic cells are healthy to do conjugation? Are hepatic cells are healthy enough to do conjugation? No. So which type of bilirubin will rise more than the other? Unconjugated over conjugated. Got it? So please understand the pathology. Yes, unconjugated. Enzymes also help. I told you which the three things you ought to see is bilirubin in serum, then fraction, bilirubin in urine, unconjugated never shows up in urine, and then bile pigments. Bile pigments are excessively high, especially in prehepatic, because it's like a tap open and everything is flowing down in prehepatic jaundice. Iron, please stick to your learning objectives. I will advise you iron to. I always advise minerals to do in the same way. What are they part of normally in your body? First, do normal. So iron? How is it stored? How is iron stored? Stored as? Where is iron stored? What is storage form of iron? Ferritin, please do ferritin first. How is iron transported? Transported as transferrin. Do transferrin first. How is iron absorbed? Fe plus 2 or Fe plus 3? Fe plus 2 or Fe plus 3? Fe plus 2. Do absorption. Do transport. Moving iron from lumen to cell, cell to circulation. Then you do regulation. Then you jump to deficiency versus toxicity. Does that make sense? Please follow that flow. Don't skip the normal biochemical role and metabolism of iron regulation, then you go there. That's why again I don't draw these diagrams because I love them. Again, okay, follow this flow. You got to understand everything. Yes, I'm just going to ask you a few questions. I have addressed them all. Did we talk about vitamin C? Does vitamin C help in iron absorption? Yes. Can vitamin C deficiency lead to microcytic anemia? Can vitamin C? Yes. Have we talked about different transporters? One for heme, non-heme, and heme ion. Where are they pushing? Where are these two transporter which are on contraluminal side? Where are they pushing ion from lumen to cell or cell to circulation? From lumen to cell, be mindful, right? Ion is stored as Fe plus 2 or Fe plus 3. Iron is stored as Fe plus 3. So learn ferritin. I'm giving you a skeleton, please. Go back to Dr. Panini's slides and do everything about ferritin and where they are assessed. We will talk about that in the last case too. I hope I'm not very fast. Am I cutting off now? Am I good? No. Okay.
Yes,
Then,
you are.
sorry. Okay, great.
You are
Then,
good.
sorry, I'm good. Okay, great. Then, who is pushing iron from lumen, from cell to circulation? What's the transporter? Transporter pushing iron from cell to circulation, ferroporotene. Is ferroporotene regulated by hepcidin? Hepcidin is a positive or negative regulator of ferroporotene. Hepcidin is negative. Now, do you need Fe plus 3 for transferrin also? Do you need Fe plus 3 for transferrin also? Look at transferrin from Dr. Panini's slides. Look at ferritin. Look at transferrin. But who is forming Fe plus 3? Hepcidin or hepastine? Who's forming Fe plus 3? Hepcidin or hepastine? Hepastine. So they are different. Hepcidin is different from hepastine. Was is hepastine membrane bound here? Yes. Is there anything in circulation that does the same job as hepastine? Is there any protein, transport protein, ceruloplasmin? What does ceruloplasmin carry? Copper. So is copper deficiency also leads to microcytic anemia? Does copper deficiency, that's why also leads to microcytic anemia? So do these first rows, then go to inflammation and hereditary hemochromatosis. Iron overload can be seen in the form of, how is iron load seen in the form of? There's an inert form that accumulates during iron overload. What is that known as? Inert, not active, an inert form. It is hemosiderin. Yes. Is hemosiderin seen in iron overload rather than iron deficiency? So know that hemosiderin, and that's why you have hemochromatosis. Hemochromatosis means iron overload leading to tissue changes. That is hemochromatosis. So then do hepcidin with inflammation and hereditary hemochromatosis. Inflammation I will bring with the question. Let's do hereditary hemochromatosis. Now tell me, in hereditary hemochromatosis, what happens to hepcidin release? Is it increased or decreased? Hepcidin release is increased or decreased? Decreased. That is why ferroporotene is active or inactive. When hepcidin release is decreased, active. And that's why now more and more ion will be pushed from. When ferroporotene is active, then more and more ion is pushed from cell to circulation. Yes, in case of hereditary hemochromatosis, hepcidin release is decreased. Yes, because there's a false sensing of iron. So you got to connect all, not memorize what's happening in hereditary hemochromatosis. Not just memorizing, oh, inflammation. So inflammation induces hepcidin synthesis or represses hepcidin, sorry, synthesis. Inflammation induces hepcidin synthesis or represses hepcidin synthesis. False sense is for false sense means there's a wrong sensing. You're sensing wrong ion stores. Missensing. False sensing means missensing in hereditary hemochromatosis. Missense. You get my point? Yes, this occurs during hereditary hemochromatosis. Yes. So what I was asking you something else. So inflammation is hepcidin synthesis induced or repressed? Induced or repressed? During induce. So not just memorizing that, but then what's the outcome? Does that make sense? So we talked about all of them. I have clearly given their roles in the slide. Please do that. Please, I think I have modified this. I just don't want to say it low because it's relative. All you need to know is I will modify this slide and send the PowerPoint again. Anyways, I'm going to post this on Canvas right now. It should be negative regulator. I think what you should understand and know that hepcidin is a negative regulator of ferroporotene rather than low or high. Does that make sense? I've changed that in the recap, but I'm going to change it again. Uh, so the thing is, very good question. Ferroporotene role is what? Where does it push ion from? There's no backward flow. There's only one function of ferroporotene. I will go over hemosiderosis and hemochromatosis. Can I finish the slides so others who want to stay will stay? I have only few slides left. I want to answer one good question. Yes, tell me, what is the role of ferroporotene? It is not pushing ion back and forth, back and forth. No, no, no. What's the role of ferroporotene? To push ion from cell to circulation. So hepcidin is, if it's a negative regulator of ferroporotene, it will just not allow ferroporotene to move more ion from cell to circulation. There's only one direction flow. Did I clear that? Is there still a question? So if hepcidin is a negative regulator of ferroporotene, that means if hepcidin is high, it will not allow ferroporotene to move more ion from cell to circulation. That's all. Okay, great. No worries. You can ask at the end. I will talk about hemosiderosis, hemochromatosis quickly. Hemosiderosis or hemosiderine is inert. You call hemochromatosis when iron overload leads to tissue changes. One difference. But hemochromatosis can also be hereditary. That's known as hereditary hemochromatosis, which is HFE protein, which is HFE mutation. Did I answer that? But I will address more questions. This triad is known as bronze diabetes. So yes, do ferritin, transferrin, then do the regulation, where it is changed. Do talk about inflammation. Do talk about anemia of chronic disease. Some students had questions, so I have got this question. So let's look at this question carefully, right? So we are talking of anemia of chronic disease, right? We're talking about the interleukins increasing, IL-6. So let's look at everything. So increase in IL-6, what do you think it does that in anemia of chronic disease? High IL-6. So where are you going when you see such a question stem? Where are you going towards? Are you going towards change in ferritin? So let me ask you, let's rule out the question answers. Are you going, yes, it's inflammation, very good answer. But are you going towards change in ferritin, which is A? Are you going towards change in transferrin, which is B? Are you going now? This is very tricky. So I will talk about C later. So are you going towards ferritin, transferrin, which is A, B, and C when you talk about inflammation? Are you thinking about that? Do you want to rule out A, B, and C, which is showing transferrin changes? Because you got to be specific. I think my internet got unstable. I'm back. I'm back. Now it shows I did mention this. I'm back. I'm back now. Am I back now? I'm sorry, there are internet issues today, but am I back now? Okay, great. So what I was telling you that you see a chronic inflammation, you see IL-6. So can you rule out changes in ferritin, transferrin A, B, and D? Do you want not to go there? A, B, and D, because you know the pathology. Yes, can we rule out A, B, and D? Now let's look at C and E. Is E the right answer? That IL-6 will induce hepcidin synthesis. Is E the right answer? Yes or no? Yes, but tell me why C is not the right answer. Why C is not the right answer? Yes, E is the right answer, but I also want you to pay attention why C is not the right answer. No, not just because of that. Not just because hepcidin is high, that means it will not have effect on ferroportin. The problem is they are saying it is increased synthesis. In IL-6, it does not alter synthesis of ferroportin. High hepcidin will alter the activity of ferroportin, not its synthesis. Do you understand that? Yes, very good. I like that answer. It only blocks. It does not alter synthesis. Yes, that is at the level of transcription. So ferroportin activity is affected with high hepcidin, but not its synthesis in IL-6. So that's why C is the wrong answer. So please be mindful. Yes, it's only an iron regulatory protein, and it's not doing hepcidin is only a negative inhibitor of ferroportin. It's not affecting its synthesis. And even IL-6 is not altering the synthesis of ferroportin. Yes, because of hepcidin, ferroportin activity may be changed. So be mindful of that. So has Dr. Panini addressed that? Absolutely. Dr. Panini has addressed the hepcidin synthesis induced by inflammation, anemia of chronic disease, and IL-6, which will alter ferroportin activity. Now let's get to the last question. So again, tell me, did you read the question? Did you read the question? So tell me, let's rule out the question. Why A should not be the right answer? This is my last question, so then we can wrap up. Why A is not the right answer? Tell me why. Please, yeah. There is no yellowish sclera. So obstructive jaundice is not the right answer. What else? Does that? Did you see the lab parameters? What should you have seen in obstructive jaundice? What should have been high, conjugated or unconjugated bilirubin? If it was obstructive jaundice, what should have been? I conjugated. There's no history of conjugated bilirubin. And secondly, sorry, there's no lab parameter change of conjugated bilirubin. Secondly, did they say there's any problem with the bile ducts in the history? Did they say there's any problem with the bile duct? Nope. So A is gone. I like the nope. Nope means not at all. Now let's go to B6 deficiency. With B6 deficiency is microcytic anemia. Yes. So can you go to B6 deficiency here? Why not? Why would you go to B6 deficiency? Because the MCV is low. Microcytic anemia, macrocytic anemia, how do you assess? By MCV. But why you will still not go to B6 deficiency? 100% reference levels are always given, but why would you not go to B6 deficiency? What should be low here is that should have been in the lab parameters. What is low in B6 deficiency? ALA, it's not seen here, right? There's no history, so B is ruled out. Can you go to lead poisoning? Why not? It is microcytic anemia. Yes. Can lead poisoning be a possible answer? Yes. But is there any change in ELA levels? Do you see high ELA here? Any of the lab finding? No. And do you see pain, glaze, potteries, batteries? No. Right? So you rule it out. Now there's only two things, either iron deficiency and iron load. See how just knowing knowledge is powerful. You can actually clearly rule out the A, B, and C. So tell me why it's iron deficiency now and not iron overload. What would you see in iron deficiency? Tell me the lab parameters. Yes, you will see what will happen to transferrin. What will happen to iron levels? Let's go first. Low. Ferritin, low. Transferrin saturation, low or high? Low. And what will be high? TIBC. Yes. So are you seeing everything here? So what should be your diagnosis? Iron deficiency. So should you distinguish microcytic anemia? Yes. B6, lead poisoning, iron deficiency. Then should you be able to differentiate parameters of iron? I'll answer the question. Can I just finish so people who want to leave can leave? Just 1 or 2 minutes left. I will answer your question. Then you should distinguish iron deficiency versus iron overload. Try to distinguish hemosiderin, which is inert, hemochromatosis, which is active. Hemochromatosis is hereditary hemochromatosis. You should be clearly able to distinguish iron deficiency from iron load. I wish you good luck, and now I can open it for question and answer. Okay.
covers 3 weeks of material. So it covers topic 10 and 11 in the digestive